You may disconnect at this time. All participants will be on a listen-only mode for the duration of the call. I would now like to turn the call over to Mr. Carl Yonder.
Thank you for joining us for the Workforce Grand Rounds webinar series, Strengthening the Rural Health Workforce, Tools, Resources, and Outcomes. Today's presentation can be downloaded by clicking on the presentation file located in the bottom right-hand corner of your screen. When the file is highlighted, you can click the Save to My Computer button. You can then save the file in the location of your choice. If time permits, at the conclusion of today's presentation, there will be an opportunity to ask questions over the phone. You can also type in any questions you have in the chat pod located at the bottom of the screen as well. The operator will provide you with instructions on how to ask questions over the phone. Thank you again for joining us today, and we hope that you find the webinar helpful. Now I'm going to turn the presentation over to today's moderator, Tammy Mayo-Blake.
Thank you, Carl. We will begin with comments from Captain Sheila Pradier-Williams, Acting Deputy Associate Administrator for the the Bureau of Health Workforce.
Good afternoon, and thank you for the introduction, Tammy. It's an honor to welcome you to our Workforce Grand Rounds webinar. Today's session is focusing on strengthening the rural health workforce, tools, resources, and outcomes. It is one of many events co-sponsored by the Health Resources and Services Administration, and I'll just say HRSA from now on, to celebrate National Rural Health Day. The events include a morbidity and mortality weekly report webinar, a behavioral health Twitter chat tomorrow, and will culminate on Thursday with the National Rural Health webcast. I encourage you to visit our website for more details and engage with us on social media using the hashtags #RuralHealth and #PowerOfRural. The goal of this afternoon's webinar, hosted by HRSA, is to increase awareness of health workforce needs in rural communities and to share innovative best practices regarding recruitment and retention of clinicians and allied health professions in rural communities. Your partnership is important to us now more than ever. The rural health workforce faces many challenges, among them clinician shortages, training, provider isolation and burnout, and an aging clinician workforce. Furthermore, with hospital closures in rural areas occurring at higher rates than urban facilities in recent years, and a pattern of increasing financial distress, more are likely to falter. Especially smaller hospitals, which are often the only health care available in rural counties to underserved patients and elderly patients with chronic medical conditions. HRSA has made great strides to address these challenges. We have made a positive impact on the health care delivery and training in rural America. The National Health Service Corps and Nurse Corps have increased the number of health professionals practicing in rural health clinics, critical access hospitals, and other health facilities located in rural areas. Just to give you a few stats, more than 3,400 clinicians practice in rural NHSC sites. 1 in 3 NHSC clinicians serve in a rural setting. 1 in 5 Nurse Corps clinicians serve in rural areas. And more than 185,000 students and trainees from rural backgrounds participated in HRSA Health Workforce sponsored programs, and that's excluding the Nurse Corps and NHSC. HRSA's Health Workforce sponsored programs utilize more than 8,400 training sites located in rural areas to provide customized academic training to improve service to rural communities. The Teaching Health Center Graduate Medical Education Program, THCGME, bolsters the primary care workforce through support for new and expanded primary care and dental residency programs, as well as improves the distribution of this workforce. Almost half of the THCGME program-sponsored residents spent at least part of their training time in rural communities. 25% of residents reported coming from a rural background. The Behavioral Health Workforce Education and Training Program also develops and expands the workforce in rural populations in the behavioral health realm. 19% of their clinical training sites are located in rural locations. And within our area health education centers, 41% of trainees reported coming from a rural background. Approximately 43% of clinical training sites were also in rural settings. So you can see we have a large rural health footprint. In a few minutes, we'll hear from our partner in rural health, the National Rural Recruitment and Retention Network, also known as CareerNET. And we'll also hear from HRSA grantees from the University of Washington and the University of Arkansas Area Health Education Centers. From their presentations, you'll learn innovative best practices related to recruitment and retention to inform your local efforts. Without a doubt, there is a lot of work to tackle. However, I am optimistic that together we can rise to the challenges facing the rural health workforce and improve the health of our most vulnerable communities. We hope you find the information presented today helpful and a complement to the great work that you're doing to strengthen the rural health workforce. Thank you for your collaboration and partnership. We can't do it without you. And now I'll turn it over back to Tammy.
Thank you very much, Captain Pradier-Williams, for those comments and for your support in this project. We will now turn it over to Christy Martinez from HRSA's Federal Office of Rural Health Policy.
Good afternoon, everyone. I am Christy Martinez with the Federal Office of Rural Health Policy, and I'm honored to be able to join the webinar today to talk a little bit about our resources and our programs. Hopefully it'll be some new information for you, and also share the panel with the great experts in workforce issues and learn a little bit about what they're doing as well. So I'll talk a little bit about HHS in rural, who we are in the Federal Office of Rural Health Policy, some workforce issues, and then specific program initiatives that we have. So as you heard from Dr. Pradier-Williams' remarks, there's a lot of challenges around rural workforce. Our office doesn't have enough money to solve all those problems, so we really look to partner within HHS and HRSA to understand what programs have activities in rural and how we can partner up and try to solve problems together. So within the Federal Office of Rural Health Policy, we do policy and research, and we also have grants that go out to communities, state and hospital programs, and then we also have grants focused around telehealth. So through all of these activities, we collaborate with rural communities and partners to support programs and shape policy that will help improve health in rural America. Within our policy role, a lot of what we do is looking at all the regulations that come out through the Centers for Medicaid and Medicare, looking at it through a rural lens, and then providing comments if we see anything that might have an unintended consequence for rural providers and rural programs. We provide the voice of rural to our partners across HHS. We also work particularly with our partners in the Bureau of Health Workforce, looking at workforce issues, working across HHS around quality issues, focusing on low numbers issues, which is a challenge for a lot of the rural providers, and being able to demonstrate quality despite having low number of patients for some of these measures. And we also have a national advisory committee that focuses on different topics related to rural, and we use that committee to advise the Secretary around a variety of issues. What's important to us, because we're working in the Washington, D.C. area, we really want to make sure that we're connected in what those issues are on the ground on the policy side. So if you have questions or if you have insights to share with us, we encourage anyone to email us at ruralpolicy@hrsa.gov just to share your insights or ask questions, and we'll try to answer those questions as best as we can. So while we cover all the wide variety of topics related to rural health, recently we've really been focused on workforce, financial viability, particularly in small rural hospitals and critical access hospitals, and around the issues of health disparities. All of this in the context of so much uncertainty around changes to the healthcare system, as things have been moving from paying for volume to paying for value, a real focus on quality, increasing pressures both at the state level and the federal level around budgets, and just uncertainty these days as to what some of these federal programs will be. We know that provides extra pressure for a lot of the already existing workforce challenges. One thing I wanted to highlight, we had worked with around the issues of health disparities. We worked with the CMS Office of Minority Health around their chronic care management campaign. It just ended this past year, or it was this past year, it just ended, and it focused outreach to both patients and providers to understand a little bit better about what are the billing options for paying for chronic care treatment for patients, focusing on rural communities and minority populations within their outreach. So if you haven't heard about this program, go to the website and find out more information about it. It's a great opportunity to make sure you're getting paid for the great chronic care management services that you're providing. One resource I wanted to highlight related to the research work that we provide in our office is the Rural Health Research Gateway. This is a website that captures all of the research briefs that we fund through our office, and we do have specific programs that focus specifically on research around rural health workforce, including Dr. Patterson, who you'll be hearing from shortly. So just to highlight a couple of the research briefs that have come out in the past year, or one that's coming up in the current year. There's one on supply distribution of the behavioral health workforce, looking at what are some of the factors that impact where medical residents choose to do their clinical rotations. And then coming up this year, looking at the supply of physicians that are waivered to treat opioid addiction in rural America. This is one of our departmental priorities, looking at opioid issues, so we're looking forward to seeing what comes out from that report. Another resource that I wanted to highlight, if you haven't heard of it already, is the Rural Health Information Hub. This is a one-stop shop for anything around rural health and human services. There's information on funding opportunities. There's information related to different resources, both federal and non-federal. And there's evidence-based toolkits, which are based on models that we've seen as being successful, both created and conducted in rural communities. So it's not taking models that worked in urban areas, but it's taking models that actually worked in rural. So one of the things that has come out related to workforce is looking at community health workers. And so these evidence-based toolkits are free for anyone and provide kind of step-by-step guides for how people can implement different types of programs to meet their community health needs. There's topic guides on the RHI Hub, and there's one specific to workforce. Another thing I wanted to highlight, since I'm sure a lot of you have some best practices going on, look at the models and innovations, and if you think that you have a model that would be worthwhile for other people to learn about and be able to replicate in their communities, please submit that as an example to highlight on the website as well. So now I'll talk just a little bit about the workforce data that we've seen, and I'm sure some of this is not new to you, but just reiterating kind of the issues that we've already heard a little bit about. So as you can see, this highlights the maldistribution of providers in rural. As you move to more rural areas, there's just fewer providers. This is another slide that really highlights provider density in metro compared to non-metro areas across a variety of disciplines. Nurse practitioners and physician assistants tend to be utilized a little bit more for primary care purposes than in urban, but throughout all of these disciplines, you can see there really is a lack of providers for non-metro areas. And then in this slide, this comes from one of the research reports that I highlighted earlier. It just shows, specific to the mental health workforce, just how much of a shortage there is in rural areas. That bullet that's, or the data point that's circled on the slide shows that 17% of rural counties have no behavioral health provider of any kind. So as we move forward into the next year, one of the departmental priorities that we're looking at is around mental health. And so we'll be trying to see what are ways that we can tap into other resources, looking at telehealth as an option potentially to really help address this mental health workforce gap for rural areas. So all of this, workforce challenges create access issues for patients, but on the other side, healthcare and hospitals and providers really are an economic driver within communities, and so it not only is a challenge because rural communities aren't getting the access to care that they need if there's a provider shortage, but it really does kind of compound the economic factors that a lot of these rural communities are facing. So a little bit about data from our partners within BHW, which you heard a little bit about some of these programs before. We've really been working with our BHW colleagues to tap into their programs to reach more rural communities as well. And one of the programs that we initiated in 2012 with our colleagues was to expand the National Health Service Corps sites to allow critical access hospitals to become sites. So we now have 50 clinicians who are serving within the critical access hospital communities. The student training, there's a huge portion of rural areas that are able to tap into BHW programs. And with the Teaching Health Center program, 12 out of their 57 grantees are in rural areas. For those of you in rural communities who aren't aware of the Workforce Innovation and Opportunity Act, this is the Department of Labor program. They have a lot of activities related to training, and healthcare is one of the areas where they provide training in. So it's a great opportunity because the grants that we have are limited to meet the need, tapping into another department's programs to link up healthcare needs within your community to resources that are available for training. So a little bit more about the Federal Office of Rural Health Policy Programs. Within the Hospital State Division where I work, we have the State Offices of Rural Health that do recruitment and training, and then we have state flex programs and grants that go through the State Office of Rural Health to support financial improvement, looking at financial viability for critical access hospitals, quality improvement, and really helping to support those health systems within the hospitals and maintain their viability to continue to serve their communities. So if you are in a rural community and you're not connected with your State Office of Rural Health, I recommend that you reach out to them. They're a great information resource to understand rural health issues within the state and other resources that might be available to you as well. So I mentioned financial viability as an issue that we're working on as a priority this year. There's been a wave of rural hospital closures, so we're just continuing to track where these closures are happening, what healthcare resources are staying in the community after a hospital closes, and then working with partners across HHS just to get a better understanding of what other models might make sense if a community isn't able to no longer support all the services that are required as a hospital facility, what other options might be available. There are some programs that we've had in the past that have been pilot projects that we've closed out now, so I've just included some slides to show over the years what we've done to really think about how we can get rural residents trained in rural communities, focusing on health IT issues as the meaningful use rolled out, making sure that people are trained and have the expertise that they need. We also had a program that we funded. Allied health is a big workforce opportunity for rural communities. So we have a grant that's just ending this coming year that focused on recruitment and clinical training and retention of allied health across 10 grantees. So one final thing I wanted to highlight is just the work that we do through our Office for the Advancement of Telehealth. I know a lot of people talk about telehealth as a solution to workforce challenges in rural. We know that in order for telehealth to work, you have to have providers on the other side who have the capacity to take on more patients. So that's an issue that we continue to look at across HRSA as well. So for the telehealth, if you're interested in setting up a telehealth program or you have a telehealth program underway and are interested in tapping into more resources, check out the telehealth resource centers. There's 12 of them located across the various regions, and then there's 2 national ones. One focuses on telehealth technologies, and the other one is on telehealth policy issues. So connect with those resource centers in your area if you haven't already. So,
thank you.
one final thing, if you're interested in just getting updates from our office, sign up for our weekly announcements list to learn about policy issues related to rural program updates and funding opportunities. And thank you very much. Please let me know if you have any questions. Send me an email.
Thank you very much, Christy, for that information. We will now turn it over to Dr. Davis Patterson and Dr. David Evans from the Department of Family Medicine, the University of Washington.
Hello, everybody. While my slides are up, I'm Davis Patterson, and I'm at the University of Washington, and I am also Deputy Director of the WEMI Rural Health Research Center, and thank you, Christy, for highlighting some of our work and work of the other Rural Health Research Centers. It's great to see that. So I am going to be talking about a different initiative, which is called Rural PrEP, and that stands for the Collaborative for Rural Primary Care Research, Education, and Practice. I'm going to go rather quickly through my slides, but you have them available for download. Just to give you a brief overview of this and save a little more time for Dave Evans to talk to you. And so Rural PrEP is another HRSA initiative, and it's through the Bureau of Health Workforce. It's a 5-year cooperative agreement, about $750,000 a year. And the overall focus of the program is to improve the nation's access to well-trained primary care providers by improving clinical teaching and research and primary care training. There are 6 different focus areas, so we're one of 6 grantees, and our focus is on training for rural practice. And so the mission that we've developed is to improve and sustain rural health through community engagement and research in primary health professions education, primary care health professions education. And we are a national project, and we're collaborating across 3 universities. So I'm the director here at University of Washington, and then Randy Longenecker is at Ohio University. He is the associate director and our lead for our community of practice activities. And then Dr. Dave Schmitz is the dissemination lead, and he is at the University of North Dakota. And then we also collaborate with non-academic partners like the National Rural Health Association, the National Organization of State Offices of Rural Health, the host for Rural Health Day and Rural Health Week, the RTT Collaborative, and of course our funder, HRSA, Bureau of Health Workforce. So the overall aims of this HRSA program is, there are 3. One is to conduct systems level research to inform primary care training, disseminate best practices, resources, and tools, and so on. And then third is to develop a community of practice to promote uptake of best practices to improve rural primary care training. And in my view, this is really what I would think of as a comprehensive whole systems approach to improving primary care. And so looking at the first aim of our project, we conduct 2 research projects a year, and our projects look at rural primary care health professional preparation, and that whether that be in school or in residency or actually in practice. And there's a list of our projects which you can come back to later if you'd like to. Also, this information is available on our website. And so we, for dissemination, we engage with our partners and use various distribution channels to share information and opportunities. Our website's listed there, and so you can find information about all of our work. And one of the examples I wanted to highlight, which is a way that we're building our community of practice, and that is to offer travel support to regional and national meetings as part of our dissemination. And so we're offering up to $1,000 per person to students, faculty, or anyone who has relevant research to present. And so that includes scholarly activity that's conducted by learners in rural places, in rural health professions education and training, and also research on rural health professions education and training for rural practice. And you can find this on our website under the Get Involved tab. And then our other aim is to develop a community of practice, and we have a number of different initiatives going there. One thing is building just a directory of rural medical school and residency programs, and we also want to highlight NP and PA programs to expand that. We also are offering, or we're proposing to offer, micro-research awards, and what that really is seed money for students, residents, and other trainees to conduct research on rural primary health care or rural population health or health workforce training. And so that's pending approval, but we expect that to be on our website shortly. We offer research design and dissemination studios, and what those really are think tanks. That's how I think of them, to improve our research and also to make sure that it gets implemented, that we can accelerate uptake of best practices. And then finally, we have a Rural Grand Rounds monthly virtual experience that we are going to be starting up. We've been piloting. We're going to be starting it up formally in January. And we have quarterly faculty development webinars. And so I will wrap up my piece here, and there's our website, and hand it over to Dave Evans. He's an investigator in our Rural Health Research Center as well as in Rural Prep, but he's going to talk about several University of Washington initiatives in medical student education that have been going on for a long time.
So, yeah, thank you, Davis. I'm Dave Evans. As Davis said, I'm a family doc. I practiced rurally in Central Oregon for about 15 years before joining the faculty here at the University of Washington about 5 years ago. So I'd like to talk a little bit about some of our workforce programs here that we do with medical students. And I need to be able to advance my slides here. There we go. Okay, good. All right. So, so the rural programs here really revolve around a chunk of the UW mission statement that says that we're going to provide the workforce needs for the 5-state region of WWAMI, which is Washington, Wyoming, Alaska, Montana, and Idaho. To do that, we have 3 programs. One is called the Rural Underserved Opportunities Program. The second is the WWAMI Rural Integrated Training Experience. And the third is the Targeted Rural Underserved Track. And I'll talk about each one of those and present a little bit of outcomes data for each. So our rural program history goes back a number of years. The WWAMI region represents 24% of the U.S. landmass and about 4% of the population living there. Roger Rosenblatt, who many of you may know, began the RUAP program in 1989 and directed it for a long time, and that's my job now. But multiple rural programs to serve these needs. The Rural Underserved Opportunities Program is a 4-week rotation that students do between their first and second year. It's a clinical immersion experience. They spend pretty much full time with a rural clinician, and you know, the goal is to have a positive image and experience in rural healthcare. The secondary goal is to be involved in the community. They do a COPC type project while they're out there. As we know, most rural docs spend a lot of time in the community, and we want the students to get this experience as well. This is a map that shows where our students are in RUAP. We placed 162 students last year from Nome, Alaska to Torrington, Wyoming, which spans about 3,000 miles. So it's a vast geographic area. The program is continuing to grow. About 60% of our students participate in RUAP. We reached a high number of 162 last year. Over the years, we've had over 2,000 students work through RUAP, and it remains very highly rated by both preceptors as well as students. We don't have a ton of outcomes data in terms of match and where people practice, but what little bit we do have comes from our local AHEC, and these numbers are presented here. These are looking at actual workforce numbers from the AMA master file. Primary care is defined here as family medicine, internal medicine, peds, internal medicine, geriatrics, and med peds. You can see that there is at least an association between participating in RUAP and ultimate practice in rural areas, as well as in primary care fields. The Wright Program, the WWAMI Rural Integrated Training Experience, is our longitudinal integrated clerkship. And Wright has been going on now for about 20 years. And what we do here is that we send students out to rural areas, as indicated on the map, for 18 to 22 weeks. The Wright experience counts for all of their family medicine clerkship, part of their internal medicine, peds, and psych clerkships, and in some sites, part of their OB and surgery clerkships as well, depending on what services are offered there. The program now operates in 30 sites, and we have 38 students each year participate. This is match data from the Wright Program with a large percentage of family medicine as well as internal medicine and peds. The next slide looks at actual workforce data. This is where people are actually practicing. So to date, we have 101 Wright physicians in the workforce. 70% are in primary care as defined previously. 35%, however, in rural areas, and that's we're pretty proud of that number. And then 15 of them have actually returned to Wright communities, not necessarily where they did their Wright, but in communities that are teaching and hopefully producing the next generation of rural physicians. Lastly is the Targeted Rural Underserved track. This is relatively unique to the University of Washington and how it's structured. And the unique aspect is that we place students in a rural community over 4 years. So they have continuous touches with the same rural community throughout their undergraduate medical education. So it begins with a targeted admissions process. We recruit and admit students who we think are most likely to practice in rural communities. The Trust Program links a number of already existing UW workforce programs like RUAP and Wright. And the unique aspect is that the students do, they start with a first summer experience, which occurs immediately prior to matriculation. They spend 2 weeks in their community there. They go back through what we call intersessions through the first and second year for a total of 4 weeks. Then they do 4 weeks of their RUAP, 22 weeks of Wright, and 4 weeks of an elective. So they basically spend 36 weeks in the same rural community over the course of their medical education. This allows them to grow into the community, really understand what goes on there, and develop an increasing amount of autonomy compared to block rotation students. The trust program is also continuing to grow. It started out with a couple of volunteer students in 2008 in Montana. It now exists in all 5 WWAMI sites with a total of 32 students a year. We're just now starting to get our students graduated and into residency. To date, we have 63 trust students who have graduated from medical school, and 73% of them are in primary care as defined previously, with 26% in family medicine. But also of note, we've got nearly 10% in general surgery, which we all know is in high need in rural areas, and the other regionally needed specialties of OBGYN, psych, and ortho are included in these statistics as well. So that's a very quick overview of our workforce programs here at UW, and I'm very happy to field any questions later or on the chat line. Thanks.
Thank you very much, Dr. Evans and Dr. Patterson, for your presentation and your information. We will now turn to Robin Howell and Amber Marshall from the University of Arkansas for Medical Sciences in Arkansas's AHEC program. Thank you.
Well, good afternoon. We are so excited and honored to be with you guys today. I've personally just celebrated my 30-year anniversary with UAMS and Arkansas AHEC, and I've had the privilege of helping to develop some of these programs. So I'm really happy to share with you a bit of what we've learned over the years. We're going to run through these slides very quickly, but we do want to give you the 10,000-foot view, and then you can download the slides later or contact us for more information. Arkansas is somewhat unique in that our AHEC program was established with state funds over 40 years ago. We have 8 regional centers, 6 of them operating fully accredited family medicine residency programs. Now, unfortunately, Arkansas has always ranked among the nation's worst in health status and provider shortages, which is why our state leaders have been visionary and long committed to growing our own providers, with physicians always being the top priority. The key point I want to make with this pipeline slide is that home-growing physicians is a very long-term commitment, and you have to invest at many points along the way to see results. We all know that research clearly shows the best way to ensure a physician workforce for your state is to first recruit them from here, and then you train them here, and then you're much more likely to retain them here. Seeds have to be planted early enough to make sure students don't miss out on core classes, and then they need interventions all along the way so they don't fall through the cracks. Arkansas has invested in 7 strategic approaches listed here, which we'll cover in more detail. Remember, we're looking at a potential 15-year pipeline, and one of our biggest goals has been to produce enough qualified applicants from within Arkansas so we don't have to recruit too many from out of state. In the medical school admissions process, preference for students from rural areas and those interested in primary care can help stack the deck to produce the types of physicians who are more likely to practice where they're most needed. Then an adequate number of in-state residency slots for those graduates is crucial. Throughout both medical school and residency training, high-quality rural and primary care experiences and support systems are very important. And finally, financial scholarships and loan repayment options can help close the deal. Now, Amber Marshall, our statewide PreHealth coordinator, who has been the central force in perfecting our pipeline in recent years, will present the next few slides.
All right, thanks, Robin. We are very passionate about our PreHealth programs. When you're looking at the entire 15-year health career pipeline, I think a lot of focus is taken off the value and the importance of these early pipeline programs. For a number of reasons, the success can be difficult to measure. It's a long time before you see results, and we tend to want quick, measurable outcomes. But these PreHealth programs are so vital considering the demographics of our PreHealth students. So here in Arkansas, we see over 35,000 PreHealth students every year, 75% of which are rural and minority students. Along with those numbers also come the challenges that rural and minority students face. So many of them don't have the same educational opportunities as students from urban areas. You know, many come from low-income families. Many are first-generation college students, so Parents don't always know how to help them with things like filling out college applications and FAFSA forms, much less how to help them get to medical school. So when students are facing all of the socioeconomic barriers, it's absolutely necessary to begin working with them early enough to provide the help they need to succeed. So here you can see a bit about our MASH program and some success we've had with it. It's our most popular program. We see about 500 students every year. And we have several programs for students from 8th grade all the way through college, and they're designed to build on each other so students can continue learning and continue expanding skills as they go along. You can find the complete list of our programs on our website, arkansashealthcareers.com. The one thing that has made the most significant impact on our early pipeline efforts would be the decision to hire 8 regional recruiters. So we did this back in 2010, and honestly, I just cannot say enough about the value they've added to our program. Early pipeline programs are important, and they're effective, but building relationships with the students and keeping in touch with them between programs is instrumental in retaining them. So when we started out, we used sort of a shotgun approach. We had programs here, presentations there, just trying to reach as many students as we could. But we quickly learned that actually very targeted and very intentional programs are the most effective when it comes to recruiting and retaining rural and minority students. And so we now focus our pre-health efforts on 3 key junctures. The first is at the 8th to 9th grade level. So research has shown that this is when girls tend to lose interest in STEM subjects, and it's also when students are taking career orientation classes at school. And so our goal at this level is really pretty simple. It's just to make science and healthcare fun and exciting. And the second juncture is at the 11th to 12th grade level. And going back to our student demographics and socioeconomic barriers here, at this level we are still focusing on health career exploration, but we're also engaging students in conversations about applying to college, scholarship opportunities, and professional school eligibility requirements. And the third juncture is at the undergraduate level, and here we're focusing on the process of applying to professional school. So we're looking at job shadowing experience, volunteer opportunities, improving their interview skills. We provide services like MCAT prep courses and personal statement review. Really, anything that we can do to ensure our students are well-rounded and well-qualified applicants. So let's look at the numbers. The UAMS College of Medicine has 174 first-year medical student slots. And in the last year, we've had 2 new osteopathic schools open in Arkansas, which have added an additional 265 first-year slots. So that's a total of 439. But if you'll notice the graph on this slide, we're currently receiving less than 400 applicants to the UAMS College of Medicine from Arkansas students. Again, we know that students who come from Arkansas and train in Arkansas are the most likely to stay in practice in Arkansas. So it's critical that we keep working hard to increase this number of qualified Arkansas applicants to medical school if we want to ensure an adequate supply of health professionals for our state in the coming years. This is a long process, but we do have results. So first, we've seen an increase in the number of Arkansas applicants to the UAMS College of Medicine since 2014. And this data is significant to us because 2014 was the first year that students our recruitment specialists had worked with began enrolling in professional school. Just last year, our College of Medicine saw its highest number of Arkansas applicants in 20 years. And in the last 2 years, we found that 30% of the College of Medicine entering classes were students that had been coached by our pre-health recruiters.
Thank you, Amber. Now I'm going to move on to medical school policies. We are very proud of our College of Medicine, and we work real closely with them. Actually, UAMS consistently ranks among the top 5 to 10 medical schools in the nation for retaining graduates, which we think is quite impressive. Now, here are some of the reasons for this success. They take a holistic admissions approach with rural and primary care physicians well represented throughout the interview and selection process. Preference is given to Arkansas students and to those from rural areas who express interest in primary care. A key factor for us has been state legislation that requires a certain percentage of every entering class to be equally distributed among our 4 congressional districts. Now, this can sometimes be very challenging, but this law has helped to level the playing field for many rural students, and has helped to make sure that students from our population centers don't always have an unfair advantage due to their sheer numbers. Once in medical school, certain things can help nurture and sustain interest. We require an orientation for all students before they launch into their first AHEC rotations, where we introduce key rural and primary care concepts. We offer community-based preceptorship, service learning opportunities, and AHEC rotations in every year of medical school. We're now in the process of working with our UAMS Office of Interprofessional Education to make sure that team-based, patient-centered care is consistently being modeled in our centers. And we sponsor family medicine and rural student groups to nurture a supportive peer culture and connection with positive role models. I think that most of us understand simply increasing the number of medical school slots in itself is pointless if there are not enough residency slots to retain those students after graduation. In Arkansas, our 6 AHEC-based residencies have been extremely important, graduating 45 new family physicians every year, with most of them staying in Arkansas. In fact, our residency programs have produced nearly half of all of the family physicians now practicing in our state, of which we are extremely proud. Support from your medical school and state legislators is critical for success, both to maintain balance between urban and rural interests and between primary care and subspecialty demands. We believe that any state institution has a social mission, actually a mandate, to assess and stay on top of state workforce needs, and then be very intentional about addressing those needs as their top priority. This should be what drives policies and incentives to encourage trainees toward areas of greatest need in your own state. If you'd like more detail on our rural practice programs, there's a link on our contact slide. Once you recruit physicians into practice, then of course you want to keep them there. So a professional support system, a collegial teaching environment, CME, telemedicine, research opportunities, and peer coaching can all help to avoid isolation and retain rural providers. Partnerships with shared missions are absolutely vital. Arkansas Farm Bureau, Blue Cross Blue Shield, and Baptist Health have been amazing long-term partners for us in Arkansas with our MASH programs. We're forging new partnerships with the Arkansas Department of Career and Technical Education, which administers the Perkins Votech Grant and STEM programs like MedProEd and HRSA. You might look for other early partners with health and career tracks like 4-H, Boys and Girl Scouts, and Cooperative Extension. We have many, many clinical partners, and we're excited to be expanding our collaborations with community health centers across the state. And in today's changing climate, we have to think outside the box and explore new partnerships at the local, county, state, and national levels, even sometimes with those we may have considered rivals in the past. So in summary, homegrown physicians is a very long-term investment, and it requires many partners. There are strategic points and approaches to maximize impact, but there are no quick fixes. Long-term personal relationships, advisors, and good communication are needed to build bridges and connect the dots for these students throughout the process. Legislators, policies, and financial incentives must consistently support and invest in the mission to ensure adequate numbers and to maintain the proper mix and balance to address the specific needs of your state. I hope you'll contact us with questions. We'd be delighted to visit with you, and we thank you so much for your time and interest.
Thank you very much, Robin and Amber, for that presentation. We will now go to Christine Morin from 3RNET.
Thank you, Tammy. Again, my name is Christine Morin. I'm the Director of Communication and Marketing for 3RNET. Thank you all for having me today, and happy National Rural Health Week. So just a little bit about 3RNET. We are a nonprofit, and we are a member association. We've been around since 1995, and we have 53 members across the country. So we have one member per state, and that member is a nonprofit or a government entity As Christy Martinez mentioned at the beginning, the State Offices of Rural Health being a great resource for folks out there. Many State Offices of Rural Health are our members as well. In fact, around 30 SOARs are also your CareerNET member. We have a couple of federal partners as well that service CareerNET members, the VA and IHS. And we've also got the Northern Mariana Islands and Cherokee Nation, our CareerNET members. So as an organization, CareerNET is best known for our job board, CareerNET.org. This is our best way to communicate CareerNET as both a trusted resource and just a great way to connect folks looking for a job in a rural or underserved area and those facilities who have those positions to fill. We provide our members with networking opportunities, educational opportunities, and I'll talk more about this in a few slides. And just to let you know, just to give you an idea, we have around 2,000 folks that come to CareerNET.org each week. So here's just a snapshot of our homepage. Again, CareerNET.org. This is what it looks like if you were to visit it today. Kind of on the top left there, you'll see for healthcare professionals, for employers, and that's where you should start. Whether you're looking to post your jobs on CareerNET or you're looking to find a job through CareerNET, that's the best way to start. And in the top right-hand corner there, you can see the register button as well. So finding jobs on CareerNET, you'll see really is as easy as 1, 2, 3. You can search for jobs. You can view limited details about each job just by browsing. You can register for full details, and then we have our CareerNET members, of course, who can provide answers. And we'll talk more about why you should register, a few more reasons, more than what I just said, and a bit more about CareerNET members in a little bit. So if you're a facility or an employer in a rural or underserved area, here's some information you should know about CareerNET. Oh, and I think I just lost my slide there. Anyway, we are a job board, and if you're registered and you have your jobs on CareerNET, you, through our CareerNET members, can access our candidate database, and we also provide some education. Oh, thank you to whoever fixed that for me. So we have over 4,000 jobs on the site. We have over 55,000 candidates who have registered on the site. And just to give you a bit of an idea, in FY16, we had over 6,000 jobs posted by facilities across the country. We were able to help almost 2,000 folks find jobs in those areas. And when you look at the economic impact of this, it's using data from the Rural Health Works folks. It's almost $2 billion in economic impact. So we have dozens of presentations that we can offer folks as well. We do workshops, we do webinars, and I'll talk more about this on the next slide. So a few resources, just again to kind of reiterate for facilities and for employers. First and foremost, start posting on CareerNET today. In many cases, it's free. Some of our members do charge a small fee just to cover their costs to be able to operate CareerNET within their state. But if you have questions about that or to learn more, please follow that link. If you have questions about workforce programs, so loan repayment programs, maybe the J1 waiver program, what are HRSAs, how do they work, what do they mean to me as an employer in a rural area, that link there, that Employer's Guide to Workforce Programs, is a great resource for you that we've put together. And also, I'll put in a quick plug for our CareerNET Academy. This is a virtual webinar series that we put on for facilities. So this year, it's focusing on How do you find your unique selling points as a rural or underserved facility? How do you communicate those to candidates to make yourself kind of stand out from the crowd? And then how do you also find what your challenges may be and invest in those? On the flip side, if you're a job seeker, if you're someone looking to work in a rural or underserved area, first and foremost, register. It's always free to register on CareerNET, and to help celebrate National Rural Health Day for the month of November, we're actually giving out $5 Starbucks gift cards for folks who are new candidate registrations. If you enter a promo code and upload your CV, we'll email you a Starbucks gift card. So if you're curious about that, want to promote that, want to register, you can go to our website, and the details on that are there. So we are multidisciplinary. We're more than just physicians, so we're a little bit more expansive than some other job boards that folks might be using out there. So we certainly do have physicians on our site, but we also have dentists, anything from a CEO to a lab tech, nurse practitioners, physician assistants, and many, many more. So please check that out, and please be aware of that. And you can browse jobs across the country. So you can indicate that you're interested in a job in Alabama and Alaska. There's no limit. And one of the reasons, a few reasons we want you to register, as I have listed here. Again, when you're registered, you can see the full information for those jobs. If you're not registered or not logged in, you can still browse jobs, but you can't see all of the details that folks have posted. And I think the best thing about registering is then when a new job is added to the site that matches your preferences, you get an email notification. So you don't have to sit and continue to search. Our site will do the work for you and let you know that a new job has been added that meets what you're looking for. Another thing I'd like to mention is a lot of the jobs on our sites are jobs that do not guarantee but qualify for loan repayment programs. So we have a lot of jobs in areas that qualify for National Health Service Corps and beyond, state loan repayment programs as well. We also have a lot of jobs on our site that qualify for the J1 waiver positions. So again, no guarantee with those, of course, but they are available on our site. Some resources for job seekers. We have some guides that we've put together. So we have one on the J1 waiver program, one on, what should I know about loan repayment programs. We always want those to be positive programs. So what are the ins and outs you should know as a job seeker? HRSAs, those are a very big deal with many of these loan repayment programs, and of course with the waiver program as well. So we have just a short guide on what those are and what they mean to you. And of course, maybe our best resource for job seekers are our CareerNET members. So again, those folks across the nation who work with facilities and with candidates to connect them and to help those job seekers find jobs in rural and underserved communities across the country. And I'll wrap it up here by just saying we're here to help. If you ever have any questions on CareerNET, again, whether you're a facility or a job seeker, please let us know. That's what we're here to do, and that's what we love to do. So there's our phone number there. You can call or text that number. We have a main email there. There's my email address. And of course, I'd encourage you to check out our website, CareerNET.org. And
thank you.
Yep, you're welcome. Thank you.
Thank you very much, Christine. And thank you to all of our presenters today and all of our participants. On behalf of the Bureau of Health Workforce, we thank you for your time and your attention. And now I will turn it back over to Carl.
Thank you. What I want to do is draw to everyone's attention. We have a few evaluation questions that we would like for you to fill out. And for those of you that are interested in obtaining CEUs, there are 3 questions along the right-hand side that we ask that you go ahead and fill out the information for. We're going to use this to package up the information, and there will be follow-up emails from APHA regarding obtaining your CEUs. But we'll need this information from you first. We'll be able to keep this information up for maybe the next 10 minutes. So for those of you that are on the call, if you can go ahead and fill out that information now, as well as the evaluation questions. And thank you again to all of our presenters.
Thank you for your participation in today's conference. You may disconnect at this time. Speakers, please stand by for post-conference.